Okay, so let's see. What we have to remember is that basically the lines that we are putting into the babies. Now these lines are not ultrasound friendly. Now these lines are, many of these lines are radio opaque. On X-ray they are designed so that on the ultrasonography you will be able to easily pick them up. The problem is these are the very small tiny lines. They are very close to the probe many times, so it is difficult to assess with a normal size or 7 or 8 megahertz probes. So you require a specialized ultrasound probe of 11 hertz or 12 hertz or maybe a hockey stick probe, which is like around 12 megahertz probe, so that you'll be able to see something which is immediately beneath the probe or very close to the skin surface. And so that is the second challenge. And third challenge is basically when you put the tube in the airway, endotracheal tube. Now, when the endotracheal tube is there, it is surrounded by air all around. Even the trachea contains all the air. And therefore, the ultrasound is not a good modality to assess the tip of endotracheal tube. Again, I mean, there are parameters which I'm going to talk, but practically the line position assessment and the ET tube assessment, it requires a lot of practice. And then one will be able to kind of identify. Now, as I said, these lines by themselves, they are not ultrasound opaque or ultrasound friendly. But what we can do to identify these lines, I will talk about it. So basically, first we'll take umbilical venous catheter. Now, for this, we need to understand the course of umbilical venous catheter. Now, this is picture on the left. If you see, so this is the umbilical vein, which is coming from the placenta, which is carrying oxygenated blood actually. So so this is blood which is coming from umbilical vein, but after birth again this is not going to be functioning. This is going to be collapse vein. Joins the left branch of so this has got a right branch and left branch, so it joins the portal vein. Okay, and and then this is a ductus venosus which joins umbilical vein into the inferior vena cava. So ductus venosus is very important. So basically umbilical vein comes like this. It is into the ligament of teres. It enters into the substance of the liver, and there it has got a ductus venosus which joins this umbilical vein into the IVC. So when we insert the umbilical catheter, it has to traverse all this and go into the ductus venosus and go into the inferior vena cava. So I'll show that figure again, but where do you put the probe for assessment of the UVC? It will be at this red area where there is a subcostal view, which is the junction of upper 1/3 and lower 2/3 of the line joining xiphisternum and umbilicus. Presentation marker is at 2 o'clock. Now the same figure I have kind of made supine, and as you can see, this is the umbilical vein coming down, and as it is coming down, it is forming the ductus venosus, and ductus venosus is opening into the IVC. So what we have to focus upon is this, that the course is like this, and in this particular view, when you're looking from this side, you'll be able to see 1 vein, 2 vein, and 3 vein. Now these first 2 veins are basically hepatic veins, and sometimes you may be able to see 1 vein because the other vein may not be there in your picture, but the ductus venosus is seen as kind of most caudal vein which is joining into the IVC. And the course, if you remember, then you will be able to identify the images and their course of it. So correct UVC tip position is at the level of ductus venosus. So if the tip of your UVC is in the ductus venosus, so this portion of ductus venosus, it is okay, no problem, or it should be from the point of entry of ductus venosus into the IVC till RA IVC junction. So this point of ductus venosus till RA IVC junction is the point, is the area where the tip of UVC should be there, and that particular area is acceptable position of the UVC catheter. Now, if your UVC stays somewhere here into the umbilical vein, again, I mean, it is not a proper position. Sometimes it goes, in fact, into the kind of left branch of portal vein. So this is the portal vein which is coming, and portal vein has a right branch, left branch. So if it sometimes goes into the right, left branch of the portal vein, and it stays here, it is not good. Sometimes it traverses this and goes into the right branch of the portal vein, goes into the liver tissue. It is not good. So sometimes it comes down like this and goes into the portal vein itself, reverse direction. It is not good. And it goes down in the portal vein, goes into the splenic vein. That is also not good. So I'll show all these pictures. This anatomic orientation is very, very important. When I started doing this, the major hurdle which I thought and which I came across is that orientation of this ductus venosus was difficult for me. And once you imagine this particular photo in your mind, you'll be able to identify where exactly the line has gone wrong. Studies have shown that only 30% of the times the UVC tip is placed appropriately. And that appropriate location, as I said, is ductus venosus, IVC up to RA IVC junction. So this is the area which is acceptable. Okay. So let's begin now. So once we understand this anatomy, it will be easier for us to kind of see. So as I said, on the ultrasound, you're doing ultrasound from top here. This is the liver parenchyma. Okay. Now this is a hepatic vein. Now the catheter is coming from up like this from the umbilical vein. Now the catheter is stopped here and the ductus venosus is here. And this is the area where you ideally want a tip position from ductus venosus IVC junction to RA IVC junction. It should be in the IVC basically. But if it is in ductus venosus, it is acceptable because there is nothing kind of tributary or there is no issue there. So this is how it will be seen. Okay. Any questions here? Because this is very important, this particular aspect. All right, I'll move on.
Can you just show the picture again of where to place the?
Yeah. I'll again explain. I think this is very important. So if you look at I'll start from the portal vein. So that again, so portal vein basically formed by basically the superior mesenteric vein and splenic vein. So they form a portal vein, right branch, left branch of the portal vein. Okay. So this is the portal vein. Now look at the umbilical vein. Umbilical vein is coming from here. It is going under the ligament of teres. It is going and it is joining the left branch of the portal vein and forming the ductus venosus, and the ductus venosus is draining into the IVC, IVC is draining into the RA. Now this course is very important to remember. Okay. So once we know that, when we put the baby supine, the umbilical line is going to come like this. It is going to come down. It is going to, there is a confluence seen here. Many times you will be able to see a large confluence here on the ultrasound. Now this particular catheter coming from umbilical vein should go down into the ductus venosus and should go into the IVC, and up to the RA IVC junction is okay. Now sometimes if you put too far in, it will go into the RA, it can go into the LA also. So but many times it is falling short or it goes into the kind of left branch of portal vein. It can stay here or it can go into the left branch and then go into the right branch and go into the hepatic parenchyma. That is not good. Or it can go into the left branch and go down into the portal vein. It is not good. Or it can go into the splenic vein. Is this okay?
Yeah, that's okay. But we just wanted to understand, you do it while you are inserting or you do it after?
Correct. So I'm coming to that. Absolutely good question. So as I said, the line catheter is not very ultrasound friendly. And so to improve the visualization of the line, we do two things. One is while doing procedure, we can do it. So that is that is one option. And so that you can actually see real time movement. So you withdraw, pull a little bit and you will be able to see the tip position. And second thing to improve the tip localization is that once we have done it, we inject little saline and that saline will be seen jetting. So the jet of saline you'll be able to see from the tip. So two things, while doing you do it and movement of the catheter will be seen, and you inject some saline and you'll be able to see the jet. So that is how we improve the visualization of the line.
Okay.
Yeah. So let's move on. So just showing you example here. Now I think see this is an image, but I don't know if you're able to see. Here is the tip of line. So this is a hepatic vein. This vertical vein is a hepatic vein. This particular is a hepatic vein. This is a heart here. This is RA. This portion is, and this is IVC, which is collapsing opening. And I don't know if you're able to see, but the tip is lying here. So correct position is RA IVC junction. So the tip is here, just below my pointer is the tip of UVC, and that is the correct position of the kind of umbilical venous catheter. Okay. Uh, it's a real time, but and you can trace it from here. It is there, and the tip stands here. Now it is, as I already said, it is difficult sometimes to locate it. You require a high frequency probe, and sometimes you have to do movement or inject, and then you will be able to see the position. Now again showing you here. Now here the UVC is positioned in the ductus venosus. Okay, so this is not a correct position, but it's an acceptable position. Now, abnormal UVC position, as I said, it is coming from the umbilical vein. Now, it can go into the duct. It should go into the ductus venosus and IVC, but sometimes it can go into the left branch of portal vein, and it can go all the other locations. As I said, left branch of portal vein, right branch of portal vein, or main portal vein, and sometimes go into the splenic vein down like that. So all those are abnormal positions. Now again here, as you can see, the UVC is gone into the liver parenchyma. So here it is kind of stopping within the liver parenchyma. So I don't know if it has ruptured the umbilical vein and gone into the hepatic parenchyma. Now we cannot keep it there like that, because it may lead to collection of the TPN or fluid within the parenchyma, can cause abscess. So this is not the correct position. Now here, as you can see on the X-ray, the tip is seen fairly at uh, lung and or diaphragm, just above the diaphragm it is seen, and one would pass it on that it is acceptable, because in 2D in two-dimensional view it is difficult to kind of see where it has gone, but when you do ultrasound you can trace it, and it has, this is RA, and through the RA it has traversed through the PFO and it has gone into the LA. Now this is not a good position, and so sometimes on the X-ray you might find the position to be appropriate, but when you actually do ultrasound, you find the tip has gone through the PFO into the LA. So sometimes we see like that. Now here, as you can see, obviously it has gone too far. It has gone through the kind of very much inside the heart, and you can measure the distance, how much you need to withdraw by ultrasound, and you can pull it back. Now again, here also you can say similarly, on picture it looks okay on X-ray, but actually it has gone too much inside, and again this much is the distance, and that you pull it back. Now complications, as I said, here on the X-ray you see the umbilical line is stopping about, well, 2-3 centimeters below the diaphragm, and one would say it is okay, acceptable, but actually in fact it is gone into one of the kind of liver parenchyma, and here the TPN has gone into the liver, into the parenchyma of the liver. So this is again not acceptable, and it can form an abscess like this. Here the line, instead of going into the ductus venosus, the ductus venosus will go like this from here point. It has gone into the left branch of the portal vein, and it has gone into the liver parenchyma. So this is, it might have gone into one of the tributaries of the portal vein, and that is not good. Now here you can see there is a clot. There is a thrombus attached to the tip of line, and again catheter ending in the left portal vein. So this is the left portal vein, and thrombus at the tip of the line. So again, this is also not good. Sometimes the line can migrate and can cause pericardial effusion. So for that, you have to do a subcostal view, short axis, orientation marker around 3 o'clock, and put it in a way that you get a subcostal 4-chamber view, and you'll be able to see collection of fluid around the heart. Now, when you have a central line in place, and when you get a pericardial effusion like this, immediately take out the central line, because most of the time the central line has migrated into the pericardial space and it has caused diffusion. Now, if this is causing cardiac tamponade, hemodynamic disturbances, you will have to aspirate this pericardial fluid. Sometimes it can lead to pleural effusion, and pleural effusion, because again the line, if it gets migrated, it can lead to collection of the fluid TPN within the pleural cavity. So that also can be aspirated. And for that, you screen at the flap point. We'll talk about in lung ultrasound. So this completes the basically UVC assessment. And as I said to you, for understanding the position of the tip of UVC, most important is to understand the anatomy. And once you understand the anatomy, then you will be able to correlate it. Plus exact identification of the location, two important things. Do it while you're putting the line. Inject some amount of saline so that you'll be able to see the tip from where it is coming, like where the tip of the line you'll be able to see. And ultrasound has been shown to have better accuracy as compared to the X-ray, because in X-ray it might look as normal, but in ultrasound you'll find out there are many other kind of problems. Sometimes it may cross the PFO, and sometimes it may go from uh, IVC, it may go into the RA and go up into the SVC also. So sometimes it may go to the superior vena cava, it may go to the one of the tributaries, brachiocephalic vein, and so on and so forth. So all complications are possible. So make sure that you kind of locate the tip and make sure the tip is at right position. Now coming to the umbilical arterial catheter. Are there any questions here, or we'll move on? I think I'll move on, hopefully. So
Yes, please do that.
yeah. So now looking at umbilical arterial catheter. Now, when we look at umbilical arterial catheter, we have to remember there is important area in the baby's abdomen where you cannot have umbilical arterial catheter. Now, if you look at the location where line should be, high umbilical catheter should be between T6 to T10. That is at the thoracic vertebra level, and this will avoid celiac artery, which is at T12, superior basic artery, which is around T12 to L1, and renal arteries, which is at L1. Or you can put it as a low UAC, where it will be at L3, L4. So essentially, you want to avoid area between T11, T12 to L1, which is the area where there are major important arteries which are supplying your gut, supplying kidneys. That area you want to avoid. Again, the principle will remain same. The baby is lying supine. You follow the line and again follow the tip, and you need to have a high frequency probe. And as you're putting the line, that time it is better visualized. To improve the visualization, you can inject some saline, and some people do agitated saline so that you mix it with little air and inject. But again, we don't recommend that. I think saline itself is good enough. And then you can assess the tip position. So again, I mean, there you have to see the as compared to diaphragm, you have to kind of put the position of the tube, and it should be little above the attachment of the diaphragm, basically. Now, evaluation of PICC, again, it is very difficult, I have to confess, because the course of the PICC is difficult to trace on ultrasound. And again, this will require a very high frequency probe, 12 megahertz hockey stick probe, linear probe, and that will give you better visualization of structures which are very close to skin surface. And again, you have to make sure that when you follow it, you have to kind of at the time of putting you do it, and this will help you kind of localize the tip. Again, you have to follow the course of the line and look up to the tip of the line. One of the reasons that this has not become so popular because it is difficult to visualize, and all things you'll not be able to see through lines. But again, this will require practice. So I think for USC and PICC only this much. Then coming to the ET tube position. Now, when we talk about endotracheal tube, there are two important aspects. One is whether the tube is intratracheal, is the question number one. And second question is whether the tube position is appropriate, that is about 1 centimeter above the carina. So for that, there are two different ultrasounds that we have to do. Now this is the one ultrasound where you use the linear probe and you put it on the cricoid cartilage, and you look for normal appearance will be like this. This is kind of a tracheal cartilage, and because it is a cartilage, it casts a shadow. Also inside there is air, and therefore this particular structure will be seen like this, and then there is acoustic shadowing, and you are not able to see anything beyond that because of the cartilage and because of the air within, because of air. And on to the left of that you have a collapsed esophagus. Now when you are putting the endotracheal tube, suppose you put the endotracheal tube within this trachea, the view will not change. It will be seen as it is seen now. But by mistake, if you put it into the esophagus, what you see is like this. The esophageal lumen also is occupied, and you're not able to see beyond anything beyond the esophagus. As you're able to see some tissue beyond esophagus, here you will not able to see anything beyond that. And this is known as double trachea appearance. So double trachea appearance tells you that you have by mistake done esophageal intubation. So real time, you are able to see esophagus here. Intubation is done. You are not able to see anything beyond. Now you are able to see. Now intubation will be done. Now you are not able. So this is double trachea. So this is a very classical esophageal intubation, where after intubation you are not able to see within the lumen of the esophagus or anything beyond that. So it will cast a shadow, and that will be seen as a double trachea appearance. So this is double trachea appearance. Now there is removed. Now the tube is put. Now you have double trachea appearance. So again, this is something which is very easy to do. And again, as I said to you, you require a linear probe, high frequency, and you put it on the cricoid cartilage, and you check it. So again, this can be done for intratracheal positioning of the endotracheal tube. Now coming to
this needs to be put horizontally or vertically?
Horizontally. So suppose this is the probe, linear probe. You're putting horizontally like this. So I've shown here in the picture horizontally like this.
Thank you.
So this is again easy to do. It looks a little complicated, but it's very easy to do, and you will be able to appreciate by mistake if there is a if it is esophageal intubation, you'll be definitely able to make sure we'll be able to make out with this. Okay. Now second important question is, where is the tip of endotracheal tube? Now for this we need to understand little anatomy. Now this is the left pulmonary. So this is the left bronchus, right bronchus and trachea. And if you see the anatomy of the arch of aorta, the arch is going little left to the trachea and going down. Okay. So what we do, we are able to see the arch of aorta very properly because it contains blood and tissue. But the trachea, being a cartilaginous structure and it has got air, it is very, very difficult to visualize trachea or bronchi. So the studies have done measurement of the tip of endotracheal tube. So here is the tip of endotracheal tube, black is. From that tip, we have done measurement either from the upper surface of the arch or lower surface of the arch. Okay. So studies have done these two different measurements. A lot of people have done measurement from lower surface of the arch to tip of trachea, and some studies have done measurement from upper surface of arch to tip of trachea. In short, this distance, that is from upper surface of trachea, upper surface of aorta to tip of trachea, endotracheal tube, should be between 0.5 to 1 centimeter. And if you're doing measurement from lower border of aorta till tip of trachea, the distance should be between 1 to 1.5 centimeter. Okay, so I'll show it. How do you do that? You do the left parasternal view. So put the probe on the on the right side, sorry, a high parasternal view on the right side, the orientation marker is facing 11 or 12 o'clock. Okay. And then what you see is the aorta, arch of aorta, and it is going to go become descending aorta like this. This is the right pulmonary artery because we are doing it from the right side. And what we do is that we do the measurement from lower border of aorta or upper border of right pulmonary artery. So here the measurement is from upper border of left pulmonary artery. So I think is by mistake is the RP. Actually, uh, it is LPA actually. So because this image will get only on a left pulmonary artery. So basically the distance is from the upper surface of the left pulmonary artery into the endotracheal tube. So this distance, if you measure, it should be 1 to 1.5 centimeter. And if you're not able to see the tip of endotracheal tube, it means that there is a high endotracheal tube. Now again, practically it is difficult for two reasons, as I said, because it is coming inside the inside the trachea, which is a cartilaginous structure. Plus, there is a lot of air surrounding the ET tube, and therefore you may not be able to crisply see endotracheal like tube like this. Okay, and this is a practical challenge, and for which we advise little upward movement or little movement of the endotracheal tube to see the tip position. So again, this is showing real time. Now this is the arch of aorta, and this is the pulmonary artery here, and this is the aorta. This is the endotracheal tube coming from up. So endotracheal tube, arch of aorta, and left pulmonary artery. These are the three important landmarks. If you are measuring from upper surface of arch of aorta, distance allowed is 0.5 to 1 centimeter. And if you are measuring from lower border of arch of aorta or upper border of LPA, the distance is 1 to 1.5 centimeter. Now people have done studies and they have tried to correlate with the weight of the baby. So this is from Gangaram. They have done this study and they have measured distance from endotracheal tip to aortic arch, and this distance they have said is 0.5 to 1 centimeter above the aortic arch. And when they have done the regression equation, the endotracheal tube minus uh, aortic arch distance is basically equal to weight plus 4.95 millimeter, basically 5 millimeters. So if the baby is 1 kg, the distance will be 1.5, like that they have said. So this regression equation they have done. So it is little higher than that. But this is a recent study which Anup and Gangaram team have done, published in Indian Pediatrics, and they have shown that this is a regression equation. So basically, um, one can see, but basically you have to see the tip of endotracheal tube and upper border of arch of aorta, and then this distance should be 0.5 to 1 centimeter. From the LPA, it is 1 to 1.5 centimeters, little higher, half centimeter higher. Now this is again the another patient, different view. This is orientation is different because this is the right side, as you can see. So the tube is coming from above, and this is the upper border of the arch of aorta, and this distance you measure, and this distance is 1.04. So that is how you can measure and take a call. But as I said to you, the trachea may not be properly or well visible like this because it is surrounded by air. It is surrounded by cartilage, and inside the tracheal tube also there is air. So the visualization is not very proper with this method. Now this is something which we did just to highlight. This distance from upper border of arch of aorta to tip of endotracheal tube is about 0.9 centimeter, which is acceptable. So again, these all better kind of shown on the patient rather than spoken about. And for you also, it is more about practice. What parameters they have taken. Once you know that, once you do practice, then you will be able to do kind of diagnose such things better way. Are there any questions in this UVC, USC, and endotracheal tube? We'll move on to. Uh, is it clear or is there any issues? Uh,
I think it's
Dr.
clear.
Dr. Sanjay?
Clear. Clear. Clear.
Clear, no? Yeah.